Hello, I'm Deborah Sims. I'm a CLL patient from Melbourne in Australia, and we're here in Stockholm in Sweden at the European Haematology Association meeting, and I'm actually with Dr. John Seymour, who is one of the doctors in my team of doctors at the Royal Melbourne and the Peter MacCallum Centre in Melbourne. And we've never actually seen each other in Melbourne, so that's quite funny. And you're here because Murano is the talk of the town here. More data coming out of the rituximab venetoclax combination therapy. Tell us about that.
So the Murano study has been published, and it establishes the safety of the combination of venetoclax and rituximab in a multinational setting, with careful attention to the dose ramp-up and tumour lysis prophylaxis. These are very active, highly effective drugs, but they need to be used with care. So we cannot become complacent, and it's really important that patients understand why these things are being asked of them for their safety with the hydration and the monitoring. So that's important. We need to get over that component of the treatment. But where we're now getting to is Murano is a 2-year limited treatment, and then patients stop therapy. That has appeal for many reasons, but we need to balance it against, is there a risk of the disease recurring? Why are we willing to stop at the 2-year point? From the earlier study, the pilot study of venetoclax and rituximab, 59% of patients achieved clearance of minimal residual disease in their bone marrow, and now 18 of those patients have ceased therapy now. Remembering this was in the earlier trial. Only one patient who is MRD negative has so far had disease recurrence. That was a patient who had 5 months of treatment and then remained off all therapy for 43 months before the disease recurred. Although small numbers, but this information is giving us an indication that once you attain a deep response, MRD negativity, it then becomes feasible to consider and explore treatment-free remission. So the Murano trial had a fixed time of treatment. At that point, about 2/3 of patients are MRD negative, and all have stopped. So that will inform us and give us indications. Are there subsets of patients where there's a greater risk of disease recurrence? Can we use MRD level, it might be negativity, it might be low positivity, to tell us, is there a subset of patients who are at greater risk of their disease recurring? Now, importantly, re-emergence of detectable disease at the MRD level does not mean becoming ill from disease. We're 1/10,000th of a level below that causes enlarged lymph nodes and bone marrow impairment. So important that patients, and all of us, understand the distinction between being able to detect very low levels of disease, and that does not equate to having disease that needs treatment, nor even imminent development of that. It just tells us that things are beginning to re-emerge, and that regrowth can be very slow.
It's really interesting how much MRD negativity is becoming part of all our language now, and particularly in the patient community, and the fact that so many people have reached MRD negative who are difficult to treat crowd, they're relapsed, they're refractory.
Their disease was difficult to treat. The people are not difficult to treat.
I don't know, I've been very difficult, I think. It's how much have things changed in terms of what the endpoint, the goal for treatment? This isn't about managing it anymore, this is about really trying to get rid of the disease.
Yes, and the updated international workshop guidelines are placing greater emphasis on MRD as a way of measuring and comparing the effectiveness of given treatment options, as well as moving towards, and we are not there yet, but moving towards using that level, that response, as a way of adapting in an individual patient. And Peter Hillman and the UK group are leading the world in that space.
Dr. Seymour, thank you very much. Thanks for being here, and I'm looking forward to seeing the rest of the conference.
Always a pleasure.
Thank you.